So I'd like to welcome everybody to the program portion of our gathering. And one of the great pleasures of Women in Philanthropy is introducing members to a wide variety of people and programs at UCLA. And so today we are highlighting women's health at UCLA. And I think that applies to everybody, or just about everybody in here. I will let our esteemed speaker tell you more about the Iris Cantor UCLA Women's Health Education and Research Center and current research being conducted, but I'd like to tell you a bit about her. Dr. Janet Pregler is a professor of clinical medicine at the David Geffen School of Medicine and has served as a role model in many areas, including healthcare, access, reproductive health, and the environment, research, and gender disparities in health. She has been recognized for her decades-long efforts on behalf of women's issues, including her work with immigrant and underinsured women. Dr. Pregler graduated from the Northwestern University Feinberg School of Medicine in 1988. She completed her internship and residency in internal medicine at George Washington University Medical Center. She was named one of 2017's Women of the Year honorees by the Los Angeles County Commission for Women and the Los Angeles County Board of Supervisors. She was nominated for the Community at Large Award by the Los Angeles County Department of Public Health's Office of Women's Health. And she has been recognized as an exceptional woman of medicine in 2019, 2020, 2021, 2022, 2023. As a side note, we see that Dr. Pregler has a 5-star rating with 135 votes in the UCLA Health Patient Experience Survey Program. She is going to share with us more about the Iris Cantor UCLA Women's Health Education and Research Center and about current research on women's health. There will be time for audience questions after her presentation. So make sure you have your pen and paper or your phone out to jot your questions down. And so with that, I'd like to introduce you all to Dr. Janet Pregler.
So good morning, everybody. And thanks so much for that really terrific introduction and short. I like that, like you really pulled it together. So I know so many people in this room in so many different ways, from someone who was working as a cardiac nurse when I was a very young doctor and sort of helped me through that, to so many people in this room who've really been essential to women's health at UCLA. And so what I'm hoping to do today is kind of split this up a little bit. I do want to talk about the tremendous impact of philanthropy on women's health, not only here at UCLA or in Los Angeles, but how the support of women philanthropists has really made a difference nationally and internationally because of what we've been able to do here. And then I'm going to switch and give you some news you can use, because I think that's, people like that. So some of the things that I think are really actionable that are new information. So some of you may know Lois Magnin. She was one of the individuals who joined our board the very first year that we had it in 2004. And she tells me that I always have to start with this because not everyone knows this. And I find that in younger generations, we're going back to this. But this is what I learned about women's health in medical school. So we learned about somebody called the 70-kilogram man. And we learned about the heart in the 70-kilogram man and the liver and the kidney in the 70-kilogram man. And then we learned about women, and we were literally taught that women were a slightly smaller 70-kilogram man. You had a little mathematical equation. I'm getting some nods here maybe from people who are in these fields. And then reproductive organs, right? But those were kind of in a box. And if you weren't an obstetrician gynecologist, you really didn't need to know about those. So really, we learned about 70-kilogram men and 60-kilogram men. And research was mainly done on men. So as an example, the very first large clinical trial of how to treat and prevent heart disease was done entirely in men in the 1960s. And that was followed up by some other studies with names such as Mr. Fit. You can guess how many women were in the Mr. Fit trial. And something called the Physicians' Health Study. And of course, back then, all the physicians were men. So we were really sort of digging a hole for ourselves in terms of research. And as we know, because you're all here supporting, a great public research institution, research drives everything that we do, right? It drives how we take care of people clinically. It drives how we're involved in the community. So this was a really big problem. So how did UCLA get involved? Iris Cantor. All right, so, and for those of you who don't know her, this says it all, doesn't it? This picture says it all, yes. So what happened is in the early 1990s, there was a group of women in Congress who had learned about, in particular, this research and medical school issue, and they wanted to do something. And so they were starting to try and get the National Institutes of Health to really think about research on women. And Iris Cantor heard about this, and so she marched into the dean's office at the time and says to the dean of the School of Medicine, "Women are not body parts. I want you to do something about this. I want to found a center." Now, I'm told that what he did, he didn't have any idea what she was talking about, right? Because this was like 1992. So he was like, "I'll get right back to you," okay? And then he went to all the chairs, which are the leaders of the different types of medicine within the school. So the chair of medicine, the chair of OBGYN, the chair of surgery, and said, "Does anyone know what she's talking about?" And it turned out that our chair at the time, Alan Fogelman, knew that there was a group of us that were trying to become more involved and to promote women's health and women's health research within the medical school. So he went back to the dean and said, "I've got a group of women for you, and they can work with Iris Cantor and get this started." So that's how we started our center. And that was the Iris Cantor UCLA Women's Health Center that, from Mrs. Cantor's perspective, had three elements. One was to take care of patients, because that's really important. We can't learn unless we're actually talking to patients. To make sure that research was getting done and that we were teaching the research to the students. And importantly, and very interestingly, she wanted to make sure that we were working with the community, okay? But she's a typical, I would say, person, and there may be people like this in this room, who kind of operates at a certain level, right? So I said, "Well, what do you mean by that?" She said, "You figure it out, okay? So you're gonna see what we figured out." But the issue that I had is that, we had the resources to do the clinical work. Yeah, we're gonna talk about Jan Cloyd.
That's
amazing.
Such a great picture.
Yeah, it really.
What magazine is this in?
So this was in what's now U Magazine. I believe it was called UCLA Medicine or something at the time. I love this picture, right? Because it just sort of says it all, and it says it all about Jan. So those of you, I think most people here probably knew Jan Cloyd. Jan was an incredible philanthropist. She was involved in sports, in women's basketball, and then she also was involved with women's health and a lot of other things in the community. But at UCLA, I think most people would think of her in those two spheres. And one of my great memories of Jan is actually, I think, it may have been because of COVID, the last really big get-together for women in philanthropy, which was an anniversary at the Luskin. And I still remember, her with her table of, women's basketball players, right? She was always mentoring them. She was terrific. But what happened I had the center, all right, but I knew I needed some funding for research, and I absolutely couldn't figure out how to get it. So I would go and talk about this and sort of hope that somehow someone would help me. And I gave a talk that Julia Gao, who you guys know, has been very active here, heard. And she came to me and she said, "Janet, this is what you need to do to get the money you need for research," because y'all know Julia, she's just like, go, go, go. She said, "You need to put together a board of women," because at the time we really thought it was women. We do have one man now, but women who are interested in this topic and who will give you discretionary funds. Because one of the things that I knew was that we have incredible expertise here. And if we allowed our scientists to say, where should we put these funds, we would be tremendously successful, but we needed something that was very flexible. So Julia talked to her friend Jan Cloyd and another friend, Christy Behrens, and I still remember, for those of you who get care here, in the outpatient plaza, there's a building called the 300 building, and we met over there. And they met with me, and it was just an immediate yes, It was immediately, we're gonna help you do this, we're gonna figure out how to do this and network. And there's a lot of people in this room who, kind of immediately signed on and got on board, and we got started funding women's health research. And we've just been hugely successful with this. It's really hard to underestimate the incredible impact of this program, which basically consisted of women philanthropists trusting us, giving us funds. We then would work with the scientific experts here. We have a scientific committee. We would have proposals from across campus on absolutely everything. So it was everything from, can we make an artificial ovary, to how can we find victims of human trafficking in the public health system and help them? And what we funded was the best science. And I was actually meeting with one of our scientists today, and it was funny. This is kind of a nerdy thing, but people know I'm a nerd. So these are completely unrestricted funds, all right? Now, one of the things that most funders will not let you do is buy a freezer. Now, you might need a freezer to keep your specimens and things, but that's not allowed. So my shorthand when I talk to administrators about this program is I say they can even buy a freezer. And I've literally had people go, what? So, this is, what we deal with in terms of, being in such a wonderful place where so much great stuff goes on, but where we need resources, and particularly as a public institution, right? So over the last 20 years, the board has invested in many things, but in this particular program, a little over $1 million. The scientists have brought back $50 million to UCLA to carry on this work. And we were hearing about, your efforts toward equity, diversity, and inclusion. When Iris Cantor told me, you figure it out about the community, what I did was I went to the LA County Department of Public Health, because I figured they were experts. They didn't teach me about this in medical school. I didn't know, what we should be doing or how UCLA could be most effective. But their Office of Women's Health partnered with us and introduced us to community experts across Los Angeles. And we had a summit meeting that was by them. And the members of the community said, these are the things that we think a university could help us with. We need to do more with environmental toxins. So that's planning for a healthy body and home. Again, I think many of you know that essentially in LA, we're living on top of an oil field. And how much that affects you depends on where you live in the city. So this was something important they wanted us to do. The idea of healthcare for LGBTQ individuals who identify as women was really not a thing. Still today, 95% of research funding for LGBTQ people is for men. So they wanted us to work on that, which we've done. And then I was really fortunate to hire and bring in a woman named Julie Friedman, who is has a master's of public health. And her passion really was the intersection between women's health and their financial literacy. So if you could teach women about both those elements together, that it would be very effective. And she has found just incredible traction with this because, this is what the community is asking us to do. And I remember when we first started doing it, we had some, quote unquote kind of academic experts say, well, that's not a thing. Well, guess what? It is a thing. And it has been very important. But what Julie has also done, to the point of some of the things that you all are also focusing on, is that she recognized that we also needed to develop future leaders in women's public health, right? So we have a program to develop leaders in women's health research. And we have a program, and I teach, to develop clinical leaders in women's health. But what about in public health? So what she has is an internship program where she takes students from UCLA, but also from around the city to work in these settings. And to be frank with you, these are often really talented individuals who, when they first got to college, simply didn't have the background to come to a UCLA. But now they get to come work with us here on these programs from community colleges and other, Cal States and so forth, in addition to our own UCLA. And I will say, we get some from USC. And we actually had a medical student from the new Kaiser Medical School who sought us out. So really a terrific group that she works with. And again, I can't say this enough. None of this, zero of this, would happen without philanthropy. There is no other way to fund it. We get grants. We have had government programmatic funding, but the reason that this is so special is because we're able to do it right because of our philanthropists. So again, remembering Jan, she started this. She was such a supporter. She was a mentor to me. Those of you who knew Jan, my other Jan story, which some of you have heard, is one of our really dedicated board members is a woman named Marianne Cloyd. She lives here in New York, and she recalls that she was at another meeting in LA, also a businesswoman, and she said, Jan walked up to her and said, Marianne, there's something you have to do. And that was the end of the discussion, right? And she's been doing it ever since. So that was really Jan, she really believed that we could succeed, and so we did. So we have many members of Women in Philanthropy on our board. This is the list I was given. Many of these folks are in the room, people who themselves are doing incredible work in so many different spheres. And this was from our annual Lunch with the Scientists. So every year we get together with the scientists that our board members have funded and hear from them. And again, I think it's really incredible to see the commitment of our scientists, again, because women tend to be interested in women's issues. They're mainly women, but not exclusively, and to see the successes that philanthropy allows them to make. So I'm going to show you one, which again, I think board members in the room are going to remember this. One of the things that we have seen a focus on over the years is ovarian cancer, because unfortunately, unlike a lot of other cancers, we haven't made as much progress as we would like in terms of curing ovarian cancer. So a lot of people are diagnosed. Many of you may have had this experience. Many respond very well to treatment, but then often the cancer comes back. And so the question is, why does the cancer come back so frequently? And people have kind of gone down different roads, but there's really the idea that we need some new ideas here. So what our board was able to fund was some work that thought about what if essentially there's traitor cells in our immune systems, or the immune systems of women that get ovarian cancer. What if the immune system, rather than attacking the cancer, is actually hiding it so that it can sort of hide out and then continue to grow? And so we funded a young investigator who wanted to follow this pathway, but like a lot of these really interesting ideas in women's health, could not get the initial funding to do so. And what she found was, in fact, yes. So she was able to identify in blue, you can see these kind of little streams of blue cells around those sort of, to us as doctors, ugly looking brown cells that are cancer. And they're sort of enveloping it or around it. So this is a first step to understand, is this really the mechanism? Now again, this really novel line of research started with another individual that our board funded, Oliver Dorigo. I still remember when he, Elaine, you were very involved in his funding, and it was actually a funny story. So he did so well that he was recruited away to Stanford, and he was there getting his blood tests to go to Stanford, and he ran into you, and he was kind of like, I'm so sorry, I'm going to Stanford, but that's okay, because that's how we build national networks of research. So Allison was actually still working with him through those connections. Allison then herself was recruited to the University of Pittsburgh, building these nationwide networks now that are going to be working on these new ideas. So I want to switch to some things that, you may be interested in for yourself or your loved ones, but I am going to kind of weave in a little bit more some of the things that are going on here in women's health at UCLA, and specifically some of the research that we've been able to support. So I think, the three things that I'm talking to a lot of my patients about this year are, one, I think we've made a big breakthrough in preventing cognitive impairment. And no, it's not, those IV medications for dementia that cause your brain to swell and bleed. That's not it, okay? It's something that you may want to do. I'm going to talk about new approaches to treating hot flashes, and this is incredibly exciting because our board really contributed to the science behind this. And then our research director, Dr. Gail Greendale, who was there with us at the very beginning when Iris Cantor showed up, she was asked by the National Institutes of Health to be part of a board to say, where should research go in menopause? And she's very focused on preventing complications of menopause. We're going to talk a little bit about osteoporosis, which for many individuals in this room may be the biggest threat to your health. Because guess what? If you don't smoke, if you eat right, if you're genetically lucky in terms of your family, it's really osteoporosis that we see as a major issue. So we'll talk about that a little bit. So dementia disproportionately affects women. We all know this. I suspect probably everyone in this room has been affected by this in one way or another, a family member, a friend. And so, we really need better ways to prevent cognitive loss. Now, it turns out that a lot of things have been studied, and some of them are, being fortunate. If you're fortunate to be highly educated, that can help prevent cognitive loss. But the things that we really know about right now have to do with alcohol and actually diet. And so, I just wanted to touch briefly on this because there is an interesting piece of menopausal research which I think actually affected me, which is there's some women who actually start to like alcohol better after they go through the menopause transition. We know that the menopause affects the hypothalamus, which is the part of the brain that really tells us kind of when we want to eat or when we want to sleep or what we want to do. But I think it is important that if you're someone who enjoys alcohol, just to understand that limiting it can be beneficial in a lot of ways, reducing risk of stroke, reducing risk of cancer, and also, reducing risk of cognitive loss. And I think one of the barriers is just understanding what are we talking about if we say 1 drink a day, and these are the amounts. Now, what about diet? And, we all hear so many things about diet, but again, I think in the past few years, we really have seen research coalescing on the Mediterranean diet. This is not going to be news to probably everyone in this room, but just in terms of how do we operationalize this if you're a woman, particularly as a postmenopausal woman. And I think, again, it comes down to really focusing on those fruits and vegetables, right? And this is hard, right? You have to plan this, I think, to get these many fruits and vegetables. Trying to make sure you get your 3 servings of fish, but remembering that's 3 ounces. That's not very big. It's like a pack of carbs. Using olive oil or other vegetable-derived fats instead of the animal fats. Again, I think we know this. Eating nuts, but remembering, again, small amounts because most of us don't have sort of a big calorie bank that we can use. If you eat dairy, I think many people here know Greek yogurt is great because it's also very high in protein, or cottage cheese, which is making a comeback. That was like my mom's favorite, and that's very healthy. But I think the things particularly for women are 2. One, if you read in the New York Times or the Wall Street Journal or whatever, it doesn't matter how much protein you eat. Don't believe that. The research is that particularly as we go through the menopausal transition and later, protein is really, really important. Why? Because our bodies naturally will lose muscle. okay? And we know this. You can see somebody who is a very, accomplished athlete in their 70s. They're not gonna look as muscular as that 25 or 30-year-old. So really maintaining that protein is important. And again, you have to think to get 60 grams. If you're trying to eat, 6 servings of fruits and vegetables a day, how are you gonna get that 60 grams of protein? That's key. And that actually also helps prevent diabetes, which is more common after menopause in women, again, because those muscle cells really chew up blood sugar. Fat cells don't do that. So if you can keep more muscle cells, you can keep your blood sugar lower. And then finally, and this is sort of the wah-wah, because I will have women come in and say, I am eating complete Mediterranean diet and I'm having an issue, with my weight. Well, the problem is the whole grains for women, menopause and later, that's like a treat, right? And so if you are gonna eat grains, by all means make them whole grains, but they're really at the bottom of the list. And it's these other things that really are the focus. Now, we have made huge strides in reducing disability from stroke in the United States. You heard, I graduated medical school in 1988. At that time, we did not know that atrial fibrillation, which again is something many of you are probably familiar with, that's when the heart, rather than beating, in a regular way, just kind of goes like that. And when it goes like that, it can form a blood clot, and then the blood clot can break off and cause a stroke. We didn't know that was causing strokes. Now we know that. So for people who have high cholesterol, if they can take a statin medication, less strokes. If they have atrial fibrillation and they can be on a blood thinner, less strokes. But the other thing that's come out recently, which is important for people to know, is that we have seen several times now an association between hormone therapy and in particular cognitive loss, certainly strokes, particularly as people get older. Now again, this is a decision that people make. I can make sure nobody ever died on the 405 in a car accident by saying, don't ever drive on the 405, right? Sometimes that's important for you and you're gonna do it. Similarly, I definitely have patients who have severe symptoms and they need to take hormone therapy. But it is important to understand that there is this association. This was published in the New York Times this year. Do hormone treatments for menopause increase dementia risk? And this is another trial which is showing things we've seen in similar trials. It's interesting because this was done in Denmark. And what's interesting in Denmark is it's a nation of 5 million people and they have all the medical records on everybody. So it's very different than the United States. So they can really do these very interesting studies where they know exactly what happened to you at every time. If you were diagnosed with dementia, they know it. If you bought hormones, they know it, et cetera, et cetera. And what they found is something that we've seen pretty consistently, which is using hormones after menopause for a little bit of time increases your risk a little bit. So a hazard ratio of 1 means 1, like there's no, the risk would be the same. So if it had no effect, it would be 1. If hormones actually reduce the risk, then the hazard ratio might be 0.8 or 0.7. It would actually be less than 1. But we're seeing a hazard ratio greater than 1, and particularly we're seeing it go high up to 1.72, getting close to like about 75% more risk if you take hormones for a long time. So again, you have to take this all in context. But this is an important piece of information as people make their decisions. But here, I think, is the take home. Mild cognitive impairment is less likely, 20% less likely, if you control your blood pressure to 120/80, okay? Instead of the old news, 140/90. Now, this was from a trial called the SPRINT trial. And what was interesting about the SPRINT trial is, the SPRINT trial, to be frank with you, I think was set up to convince doctors not to give older people as much medicine, right? They said, we're gonna show those doctors that it's fine. You don't have to treat blood pressure as aggressively. It's all gonna turn out the same, okay? Well, guess what? This is why we do research. It was the opposite. So within only a few years, the Data and Safety Monitoring Board, which looks at this to make sure that people aren't being harmed by being in the study said, you know, we can't keep telling people that 140 over 90 is okay in that 140 over 90 arm, because we are seeing more cognitive impairment in the group that's being treated to that higher number. So
Cognitive impairment study only on women or women and men?
women and men, and of course mainly men, about 75%. But we think it's true for both from other data. Good question. Mild cognitive impairment, many of you are familiar with this. It's not yet dementia, but it is something where there's cognitive changes that you can detect. And one of the things that's really been in the news lately, which you may be familiar with, is mild cognitive impairment makes people more likely to be a victim of a financial scam. So have you guys seen that? There was an article in the LA Times about this. And I'll never forget, I had a patient come see me with mild cognitive impairment. It was just by luck. It was like her, 3-month blood pressure check. And she walked in and she said, well, I'm really worried about my son. He's in jail and I sent $120,000 to his lawyer. And I knew her family. I said, I was thinking in my mind, you mean your nerdy son who's the lawyer in St. Louis? What? And so it turned out she had gotten one of these calls, I'm a lawyer for your son. He's embarrassed. He won't talk to you. Please send me the money. And again, with mild cognitive impairment, she, didn't sort of see the red flags with that. So what I was able to do is I told her, do you trust so-and-so, your daughter? Would you talk to her about this, even though I know your son might be embarrassed? And she did. And fortunately, then she didn't transfer the next, $120,000. But these are the risks, that we can see even with this relatively mild, level of impairment. So these are our new guidelines from the American Heart Association, and you can see now that we're really considering above 120 to be elevated. Now that doesn't mean that everybody has to jump onto medication right away, but I do tell my patients, I think you want to think about this. And I think you want to think where you want your number to be, and how can we try to achieve it. But certainly aiming for that number is good. And again, we've had research all over the place, 10 or 15 or 20 years ago, we had people saying, oh boy, if that second number's low, that's a big problem. It turns out we're really not seeing that. What we're seeing is this, and this is very consistent. So I heard a talk from Dr. Carol Watson. Many of you may know her. She's a really outstanding, internationally renowned cardiologist here who heads the Streisand Center for Women and Heart Disease. And she said, this is absolutely true. This is what we've seen in a lot of data, but this trial really proved it. So again, 120 over 80, get your blood pressure checked, and just know as a woman, particularly if you've been a fit woman, you may not develop high blood pressure until you're much older. But just because you didn't have it when you're young doesn't mean you won't get it when you're older. And actually, the older you are, the more likely you are to get high blood pressure. So let me just finish up here with a couple things that are a little bit quicker, which is hot flashes and best exercise. So we are fortunate here to have a researcher named Stephanie Correa, and she's a true super duper star. And we were able to recruit her. She beat out 399 other applicants for a funded research position after she did her initial work at UCSF. And what she works on is where in the brain do the hot flashes come from, okay? And we knew that they came somewhere in the brain because we knew that certain medications that affect the brain, like antidepressants, could make hot flashes less, and certain anti-seizure medications. But she actually did the work to figure out where this was. And again, our board members in the room may remember this. She was the one who gave the mouse a hot flash that lasted 3 days. So what happened was when she identified this part of the brain and zapped it, she had these pictures of this poor mouse, just kind of like this for 3 days. So where did this lead? And again, these are things that happen nationally. Different people work on this around the country. She made very important contributions to this. And now we have a drug, and I'm actually going to be showing this at a national meeting for internists. But the reason that we get hot flashes is that center place is sort of what controls our temperature. And then that thing on the left, those are nerves that kind of influence it, okay? So normally, before menopause, if you have estrogen, it keeps those sort of influencing nerves calm. But when your estrogen levels drop, those influencing nerves just kind of go bananas, and that's why, you know, we end up with hot flashes. So one way to calm down those influencing nerves is to give estrogen, but not everyone can take that. So knowing exactly which nerves were involved allowed us then to develop an alternative drug, which is non-hormonal. And you guys have probably seen the ads. This is Veoza. So you can see her, she's like putting out the hot flashes there. You know, so this shows the direct translation of when we figure out the science, then we can have treatments. Is this the magic bullet? No, like a lot of first iterations, it can cause some liver inflammation, other things, it's not for everybody, but we're gonna get there. And this is gonna be really important, particularly for my patients who are really suffering. As an example, they get breast cancer, they go into menopause, they can't take hormones. You know, now we've got some better alternatives. And then finally, osteoporosis. So, you know, if we're honest, most of us over 60 have done that, right? At least once. And it's a difficult discussion I have because, again, we're all strong women and we're like, no, I was distracted, it was this, it was that. But we all know that as we get older, we're more likely to have that happen. And, you know, it sounds like you in the room are very knowledgeable about this. Osteoporosis can end your independence, right? You can die after a hip fracture, usually not from the hip fracture itself, but you have to lay around, you get a pneumonia, you know, other things happen to you medically because of the hip fracture. You know, even more so, not able to walk independently, not able to do the same sort of activities of daily living. This is really, really important, right? And so there's two things that have really come out of the research that Dr. Greendale's done that I want to point out. One's immediate, and one is how she's contributed to the research agenda going forward in the next 10 to 20 years. So what we've learned, and again, I think women at your level of sort of interest and knowledge have heard this because I'm seeing this as my patients come in, is that you need to do weight-bearing exercise, but you also need to do muscle strengthening, right? And I think we all remember, you know, 20 or 30 years ago when you saw women who were sort of chic, right? That upper body, very thin, you know, thin arms, not muscular. People even like to avoid looking too muscular. It turns out that that kind of training is key, particularly for maintaining the strength of the upper spine. So in addition to your weight-bearing exercise, walking is good, but if you can do something a little more than that, it's even better. You want muscle strengthening. And then the third thing, which is, anybody want to shout it out? What am I missing here that you guys all do? Cardio, yes. Yoga or Pilates or Tai Chi, right? Because in order to break your hip or break your spine, you have to fall down. So balance exercise, really, really important. Whatever works best for you. And then I just want to finish up here. This is what Dr. Greendale presented to our board at our last lunch with the scientists about what she told the National Institutes of Health when they invited her to be one of 3 people that would talk to them about where should research funding go in menopause. And this is a lot of scientific lines, right? But I'm going to tell you what this shows. So where it says red menopause right there, that line, okay, that is the final menstrual period, okay? So that's usually somewhere in the late 40s, early 50s, okay? And what you're seeing, the first yellow line, all right, that's what happens to your bone density, all right? So you can see that right around that last period, your bone density takes a dive, all right? On the other side, you can see a line that shoots up like this. And what's that, everybody? Right, body fat. So, right, it's the menopause, yes. Yes, Dr. Greendale has termed it the menopooch, and she's gotten hate mail over that too. So, what Dr. Greendale is pointing out is that we have this moment in time when we go through the menopause transition where a lot of things happens to our health. And is there some way that we could intervene right there, right? With something that would change that trajectory without, causing side effects or problems or being something that when you take it when you're 80, it's not good. So this is really where she is sending the research. So this is my summary for today. I want to thank each and every one of you for what you do for UCLA, and I'll open it up for questions.
Julie, did you order the baking of the chocolate chip cookies? I think you're right, that's all. This is torture.
You're right. You're right. Yes.
So we don't have a microphone, so could you just kind of stand up so we're ready?
Okay. I have low body fat.
Yeah, I like the upper body looks good. Yeah.
My question is about the hormone replacement therapy and the controlled study that they did. I'm assuming that was all on women.
Yes.
In that study, how controlled was that trial? Did they account for high blood pressure? Did they account for obesity? Or did they just take, these women have been on hormone therapy for more than 12 years, and now they're showing more dementia?
Yeah, it's a good question. Yeah, it's a good question, and they did try to control for those things because that is really important. But the other thing that I would say, which I think you're bringing up the point, is that
Fitness level too has got to be a big factor.
yeah, so again, I just want to be clear. I am not saying nobody should ever take hormones at all, okay? What I am saying, because again, I decided not to have my first kid till I was 32. That made my hazard ratio for breast cancer go up to about 1.24, okay? So there's a lot of decisions we make, and we're not going to wrap ourselves in a bubble. But what I tell women is just be knowledgeable about your choices. So some people in this room have heard my point of maximal fame was when I was interviewed on people.com. And the reason it was my point of maximum fame was the realtor working with my mother-in-law, who has the same name, Pregler, said to her, "Is that your daughter, Janet Pregler?" And Tula was like, "What are you talking about?" Well, I was interviewed on people.com because there was an obstetrician gynecologist in Santa Monica who had cared for a lot of, well-known stars and, people that everyone knows who they are, who was sanctioned by the medical board because several of them had had complications. And the reason she was sanctioned was not because they had complications. I mean, I give drugs that have complications. She was sanctioned because she told them hormones have no bad issues at all. They're completely safe. And even when 3 of these women started to have symptoms of uterine cancer, which is a possible complication of hormones, particularly the way she was giving them, she told them, "Oh, it can't be the hormones." And the quote, not from me, but it was from another, expert, was, he said, even I know that if you water a plant too much, it's a problem. Like nothing that you take or put in your body, has no, possible side effect. So again, I don't want anyone here to say, if you're on hormones, if you feel good on them, if you need them for symptoms, I'm not saying this means you should stop. But I'm just saying that it's good to reassess everything that we're doing for our health, and just to be realistic.
Find out what the upper limit should be on that, 80, 85?
Well, or as my mother has told me, you're going to pry it out of my cold, dead hands, and she's 90. And I haven't told her to stop, by the way. She just came up with that on her own. No, I think what we see with hormones is that, and again, the theory behind this, but we shouldn't go by theory, we should go by research, is that our bodies change in other ways other than just hormones, right? And so the idea is as you get older, your body really, it wasn't sort of evolved to have hormones at the level of, being 50. So I don't think there's any strict cutoff. And again, if someone is miserable and really needs their hormones, this is not a no. But on the other hand, I have had women come say to me, well, I feel great, but all my friends take this, should I take it? And my answer is, like anything, it can have side effects. Yeah, so that's all with that.
Okay, I have one more question.
Yes, but thank you for bringing that up because I know a lot of people were thinking that.
The community engagement clinics that you have, there's one in the San Fernando Valley and a lot of other places. I live in the San Fernando Valley.
Oh, terrific.
Are those engagement places embedded in UCLA health clinics or in schools, or where do those typically hang out? And then I wanted to make one more comment.
Yeah.
Most drug studies are on men.
Yes.
And they develop all these drugs on men, and they have completely different results on women. Okay.
You are 100% right about that. So these are different organizations that we work with, and in fact, these are not. There may be one or two exceptions, but they're not clinical care. So as an example, these are a group called Rising Communities that does community engagement work. A group called Black Women for Wellness that does health education for the Black community. There are different community groups that then work with us on these public health initiatives. Yeah, so not clinical care, but thanks for asking that. Yes? Okay, so who, I'm sorry if I, yes.
I'm backtracking. The hormone therapy, just in drilling down, there's usually 2 different hormones, maybe more.
Yeah.
And was there any focus on, particularly with the dementia, on whether it was caused more by, or exacerbated more by estrogen or progesterone?
That's a really good point. So now we're going into this could be my med students here, but yes. So when we give hormone therapy, we give the 2 hormones that the ovaries make a lot of different things, but we give 2 hormones that the ovaries make during our reproductive lives. We give estrogen, which as you saw, that's what's helping the brain and everything. But then we also give progestin, which if you don't give it, women develop uterine cancer if they have a uterus. And that was shown very well because the first go round of giving hormones for menopause was in the 60s, and they just gave estrogen and they saw, uterine cancer. Within 3 years, you'll start to see changes if you have a uterus. So it's absolutely true that when we give estrogen alone without the progestin, we see a lot less side effects. And so it may be that if you don't have a uterus and you don't need to worry about uterine cancer and you're only taking estrogen, that these risks may be different. The one caveat is we do see the increased risk of stroke and blood clots with estrogen alone. So again, estrogen alone is not free of issues, but it has many less issues, and so you're 100% right. When I'm talking to a woman who's had a hysterectomy, those risks are different. Yeah, for sure. Yeah. Yes.
I was curious about your study treating ovarian cancer. How can I protect myself, or how can I make sure that I potentially might not have any of those hidden fellows?
Right. Ovarian cancer is very difficult because I would say, like pancreatic cancer, we're still at a stage where there's really no way that we can guarantee a woman that she won't get it, even if she has her ovaries removed. And the reason is that we now know that most ovarian cancer, not all, but most actually starts in that little fallopian tube, the thing that connects the ovary to the uterus, okay? That's why, as an example, there were trials done, including at Cedars-Sinai, of doing ultrasounds. Let's do ultrasounds just like we do mammograms. Let's find the cancers early. What they found was they couldn't find them early because they gestate in that little tube, which we can't see on an ultrasound. And then by the time, you can see them, it's gone too far. So we really need research on how to figure that out. If I could be like Star Trek, this is what I would do, okay? I would have a little nanobot that would do like a colonoscopy, but it would do it on your fallopian tube, right? It would crawl through your fallopian tube and look for changes. But, we're just not there yet. So I think the one thing that you can do, the one thing is there are family genetic syndromes of breast and ovarian cancer. Most of you have heard of BRCA. Again, our board is actually supporting identifying women with BRCA who are at the county hospitals, because for years and years we thought BRCA affected Jewish women. We now know that it's also very common in Black women and some women from certain parts of Central and South America. So if you have a family history where there's ovarian cancer in men in particular, breast cancer at younger ages, this is not going to be grandma got it at 80, but younger, then you do want to have a genetic evaluation. And removing the ovaries can greatly reduce the risk of ovarian cancer. Unfortunately, not eliminate it, because sometimes there's a few of those cells that are in other parts of the abdomen. But it's really knowing your genetic risk at this point. But that's why we have such a heavy focus on this. We've got to do better. Yeah. Yes?
Thank you I really appreciate all this. I don't want to have a separate panel discussion about my question. It's just more to see if the research is moving that direction. We can always talk about that. And thyroid cancer doesn't recur. It's supposed to be the cancer that it's like the one you want to get.
Yeah, doctor, I always say that. That's like a dumb doctor thing. We say, oh, congratulations, you got that.
Really? And they don't tell you that there's a 15 to 20% recurrence rate. And I'd love to know if the institute, what you're doing, because this is all hormones also, right? So it's what does this look like for women because women with thyroid problems, low thyroid, underactive thyroid, not just thyroid cancer, there's so many different thyroid irregularities. And I would love to understand, you could have people have thyroid malfunction all the way.
100%, and it affects fertility. It can affect the success of your pregnancy, and it affects fertility. It can affect the success of your pregnancy.
And all the things you talked about.
Right, and all this stuff. So this gets back to this picture, right? This is actually what I teach in the medical school, which is that the hypothalamus controls all these different things in your body. And what the hypothalamus does is it sends signals to a little gland called the pituitary gland, which is also, in your brain. And then those hormones go out and they tell your thyroid what to do. They tell your ovaries what to do. They tell your adrenal glands that make steroids what to do. Okay, and all these things are interconnected and crosstalk. So you're right. One of the struggles that we have is we can give, as you well know, the hormone that your body makes for the thyroid. But the problem is, how do we know what the exact right amount is for you? And the other problem, which I think you know, is if your thyroid's intact, this is a dynamic system, right? So like if I'm a little nervous right now, my brain might be saying, oh, let's dial up the thyroid hormone a little bit because the heart rate will go higher and then I don't know what, but right? And so the issue is if you've had your thyroid removed, you're taking a stable dose. And we try and adjust that by, doing slightly different things with 2 different forms of thyroid hormone, et cetera, but you're 100% right. And so I think that the hormone research is very important, and I'm here, so I'm just gonna say it. These are primarily women's issues. They have been ignored. And so by promoting women's health research, we can do this. And I realized there was one last thing I wanted to say to thank all of you. Our board was instrumental in getting me an endowed chair, which gives me additional financial resources to help do things, but also gives me a certain stature, frankly. And yesterday I was on a call with the White House, yay, with some of the other, women's health research leaders in the US. There's going to be a new White House initiative. Some of you may have heard this on women's health research. And and you're like, yes, and and the person leading it is a woman named Carolyn Mazur, who got one of the very first endowed chairs in women's health research in the country. Who was the donor? A woman, right? And she really knows. So she knows, as a matter of fact, what our board knows, that part of this, and to your point, is to get the NIH to do the right thing, to get the FDA to do the right thing. Within the last 5 years, the FDA approved a medication to prevent HIV that had only been studied in men. Still. And, you know, we're like, that is not acceptable. Like, you cannot approve a drug for something that affects both men and women without studying it in women. So, you know, you know, your point is we got to learn a lot more about this. And ultimately, it may be that we'll have a little implant that gives you thyroid hormone just at the right level. Yeah.
It's also because it leads into women with healthy thyroids have all these challenges. So it'd be interesting to figure out, so many women don't have healthy thyroids. They don't even know they don't have healthy thyroids.
Yes, absolutely. Yeah. All right, one more, and then we got to go, right? Last question. Yes.
I think this affects a lot of people in this room, so I'm going to ask the blood pressure question.
Yes.
There are a lot of diabetic or pre-diabetic people, and one of the things they do in order to prevent or mitigate kidney damage is, and I don't even know if they know all the reasons, but they give high blood pressure medication.
Right.
For that reason, not even if you have normal blood pressure. So the question is, that seems like the horns of a fatal dilemma. Do people with low blood pressure better off taking blood pressure medication to avert kidney problems? Or should they not take low blood pressure medication because they really don't need it for their blood pressure?
You know, that's a great point because, again, some women have issues with high blood pressure, but some women have issues with low blood pressure, et cetera. What I will tell you again is this points out the importance of research, okay? So when I was an intern and resident, we were told if somebody's diabetic, you just put them on those medications you're talking about, usually something called an ACE inhibitor or an angiotensin receptor blocker. People call them ACEs or ARBs. But then, again, researchers stepped back and they said, well, do they really benefit everyone? Or is it only some people where we're seeing more of an effect of the diabetes on the kidney? So we now know that whether or not it's really important for you to do this depends on the amount of protein that we measure in when you have a urine test, when you have diabetes, and that it's not one size fits all. So now again, this is evolving literature, and I would say not all doctors have totally caught up to this yet, but it certainly is something to bring up if you're noticing side effects, to say, you know, well, what's the level of protein in my urine, and if I have a little or not any, you know, am I going to benefit from this? Yeah. All right.
So ladies, all I can say is, oh my gosh, and thank you. Thank you, Dr. Pregler, for creating time out of your schedule to come and share more information about the Iris Cantor UCLA Women's Health Education Research Center. I know there are a lot of your board members that are here, and I know a lot of your board members are also members of Women in Philanthropy. So thank you all for attending. Just a reminder that we hope you'll be able to join us for our member meeting and program Exploring the Depths of Human History and Heritage with Professor Justin Genevant. UCLA Maritime Archaeologist and Professor on Wednesday, April 10th. So I mentioned our next meeting is April 10th, so now you have the subject matter. A reminder, if you, yes, Kathy?
I just want to make a reminder also for Sunday, March 3rd.
Oh yeah, I was getting there.
To join us
I got a whole
for the
script.
staircase tour.
I got a whole script there.
So,
Whole script here.
add on to
Whole script here. They don't let me forget anything.
for some exercise.
So yeah, because many of you were not in the room earlier, I'll mention that now to Kathy's point. We have an activities group on the painted stairs, and that's Sunday, March 2nd. It was rained out.
March 3rd.
March 3rd.
Okay, you're paying attention. Very good, you're paying attention. It's March 3rd. There's still space available, so contact Melissa if you're interested. That's a midday, March 3rd, weather permitting. So it looks like hopefully there'll be no rain in the forecast. And I believe we're doing lunch afterwards?
Yes.
Yeah, we're doing lunch afterwards. Also, I would just like to remind you, in case you've been under a rock, that Women in Philanthropy is 30 years old, and we've never looked better. And we're celebrating our 30th anniversary on May 1st under the dynamic leadership of our co-chairs, B and Vicky. So we heard from the anniversary. We're at the Leslie Conference Center. If you're a board member and you weren't here earlier, just know B, Judith, or myself will be reaching out to you very soon. We hope all of you will be marking your calendars to attend.